So welcome everyone. We are so thrilled to see you all here today and to celebrate this culminating experience in the MSPH program for our students, Jennifer, Adrija, Caitlin, and Sarah. I'm not going to take up too much time at the start because we're excited to hear about all the work that you guys have been doing over the past year. So I will I'll introduce our first speaker, who's Jennifer Choi. Jennifer received her Bachelor of Arts in Public Health from UC Berkeley, and today she's going to be presenting her master's essay titled The Impact of Green Space Valuation on Depression Among Adolescents in Baltimore. So Jennifer, you can go ahead and take it away.
That sounds great. Thank you for a kind introduction. Okay, 1 second. All right, is everyone able to see my slides?
Yes,
awesome. Okay. Hi everyone, my name is Jennifer, and I'm really excited to be here with you all today. I'd like to first take a moment to thank Dr. Mari and Dr. Jenkins for being such strong pillars throughout my thesis writing process. And as a team, we're really excited to be sharing our findings with you all. So let's start with what inspired our research. Well, we noticed that there are 37,000 vacant lots and abandoned buildings in Baltimore. We also know that there are nearly 32% of adolescents in Baltimore that are reporting feeling sad or hopeless, and 20% seriously considering suicide. So the question is it a coincidence? Or is there an actual relationship between the high number of vacant lots in Baltimore, as well as the high number of adolescents in Baltimore reporting depressive symptoms? Well, to examine this in more close detail, Project Vital, a study launched by Dr. Mari, collaborated with many different community organizations, and with a collective aim, examines the impacts of greening vacant lots on adolescent health, with mental health being one of their focused health outcomes. Okay, so what was the research prior to Project Vital? Well, the current research really focuses on the impacts that green spaces have on health of adults. And studies have shown that adults that live near green vacant lots or green spaces report having a lower risk of developing mental health conditions, as well as there's a reduction in crime and violence in the neighborhood. But Project Vital noticed that there is a gap in research. There is very limited research done on adolescents. So they're collecting data and kind of really focusing on this same research focus with understanding how greening vacant lots really do impact adolescent health. Where my paper comes in is we're really looking at a very specific subset. We're understanding, regardless of whether adolescents live near green spaces or not, how do they value green spaces, and whether green space valuation actually has an impact on their mental health. So in one collective thought, my paper aims to assess the impact of green space valuation on adolescent depression in Baltimore. And how do we go about assessing for this? Well, to no surprise, we're using Project Vital's data. And Project Vital, with their many community health events, they surveyed 14 to 19-year-old young people and retained a demographically representative sample of 355, of which 103 value green spaces. And actually, how we got this number was through the survey question here on the slide. We asked them, what do you like best about your neighborhood? To which they responded, green spaces. There were other 4 options, including location, people, access to public transit, and other. But only those who marked green spaces were accounted for in the 103. Additionally, 184 reported depression, and this was according to the Center for Epidemiologic Depression scale. As a whole, of 355 young people, we had an average age of 15.55 years, with adolescents predominantly identifying as non-Hispanic, Black, female, and from 8th grade. There were a lot of demographic similarities across groups. To kind of give you an example here, on the accounts of age, race, ethnicity, and grade, there were a lot of demographic similarities between those who value green spaces and those who did not, those who reported depression and those who didn't, as well as across those exposure and outcome groups as a whole. And we noted that there were 2 notable covariates for specifically just adolescent depression, and that was gender and food insecurity. But I will spare the details now because we'll go into more detail later on. But just noting that these were only specific to adolescent depression and not green space valuation. For uniquely just to green space valuation, there were 4 significant factors. And to highlight a few here, those who value green spaces were more likely to visit green spaces more frequently, specifically a few days a week. And additionally, those who value green spaces were more likely to mark that there were abundant green spaces in their neighborhood. The other two variables were regarding the time that they spent outdoors, not just green spaces, as well as whether they marked that there were unclean vacant lots in their neighborhood. And these, again, were only specific to green space valuation and not adolescent depression. Okay, so we did a logistic regression test, and in our model, we adjusted for green space valuation, food insecurity, and gender. And for our main result, we found that there was a modest relationship between green space valuation and adolescent depression, but that near statistical significance. So in other words, we had a null finding. There was no significant relationship between green space valuation and adolescent depression. But according to looking at the odds ratio, we do think it suggests that there was a protective factor, but unfortunately it wasn't significant. However, what does this really mean, right? What does a null finding mean here? Well, we have two explanations for this. One is depression is truly a very complex mental health condition, right? There are many factors that really play into why someone has depression, and one of which is gender. There in literature as well study that there is a gender difference in depression rates, in which that young women more than young men are more likely to report depression. And this could be stemming from the fact that there are gender differences in stress coping mechanisms, as well as sociocultural influences that really do impact mental health. And in our study, through our secondary analysis here, after adjusting for green space valuation and food insecurity, we found that young women participants were nearly twice more likely to report depression than young men participants. So it really shows that our results corroborated with what was seen in literature. Additionally, food insecurity is truly another critical factor that plays into depression. Those who are food insecure are more likely to report depression, and this really goes with the understanding that when young people's basic needs are not met, right, green space may not hold a high priority value. And in our study, we found that after adjusting for gender and green space valuation, food insecure participants were nearly 4 times more likely to report depression than those who are food secure. So as a whole, these two factors really do highlight the complexities of mental health condition and why we may have seen a null finding. Additionally, why we may have seen a null finding was because of a study limitation. We did have a relatively small sample size. Of the 355 young people, we had 103 that value green spaces. So it really goes with the idea that had we had a bigger sample size, could we have seen a statistically significant result? And that could have been the case. But that really goes with this idea, and for my first implication, that we need more research. Luckily, Project Vital has a lot of new data that's rolling out soon. For example, there's a database on all the green spaces in the neighborhood, as well as observational data for green to vacant lots that are within a 0.2 buffer zone for each survey respondent. Additionally, some other research interests that they do have is looking at the different types of greening interventions, if they have a different effect on mental health outcomes for adolescents. Overall, all this research is super important because they will inform policies, right, and decision-making processes regarding vacant lot restoration, greening, and to really go with this point here, and what I would argue is one of my main important takeaways of this presentation is hopefully our research really underscores the importance, or actually a very often forgotten voice in research and decision-making, and that is young people. It's not just adults that are using green spaces and vacant lots. So it is important that we do value all the voices in the community and actually really value and hear what young people think about what needs to be done in the community. So one more time, just reiterating, we need to incorporate young people more into the decision-making process. And I really enjoyed sharing my presentation with you and all the findings. I hope you enjoyed that presentation as well, but I'm open to hearing your questions.
Thank you, Jennifer. Thank you for a wonderful presentation. And now we'll open up the floor to anybody who has any questions following up on what Jennifer presented. And maybe, Jennifer, you can stop your screen share.
Oh, yeah. Let me do that.
Great.
Any questions for me? I don't bite either.
I have a question.
Yes.
I was really excited to hear about your findings and your research. I know that there's a lot of really important work being done on green spaces, so appreciate you sharing your research. I was just wondering what you think the next steps are for your research, and if there's any policy routes that you want to go down, or just any future research that you want to conduct.
Thank you for, for being interested in the my research findings and everything. I think this is a really good question. For next steps, I really do think before, we go further into just like straight up policy making and everything, there needs to be a lot more research to be done. As I mentioned earlier, like I think maybe we need more qualitative data and actually, yes, our survey questions were more like just asking what they value about green spaces, but the next step would be to really ask qualitative information, like why do they value green spaces, or what about green spaces that are really important? Do you like the community gardens versus just parks? And that, with understanding this information, I think that could later be used down the line as like, okay, how do we take what we have as our resources and funding to really better take that investment and really put it to, actually building those or greening those vacant lots. So I think that's something, I think our first priority should really be about generating that research, and, stay tuned. There will be more research that are going to come out. But I think currently what community organizations can be doing with the current findings that we have is, if they're not actually incorporating young people's voices already into their discussions about that, they should start there and like really hear their input and not just have adults on the committee, or maybe just create like a youth committee. And through that, they could have more effective communication on what they should do, as this is a community joint effort. So I don't know if I really answered your question, but those are my two main ideas, I think, just like maybe from a community organization perspective as well as research. Yeah.
Great. Thank you so
Thank
much.
you.
We have time for one more question, but if it seems like, leave it open. If it seems like folks don't have any questions, then we'll just say thank you to Jennifer again. And if anybody has any follow-ups, you can feel free to reach out. Our next presenter is Adrija Chakrabarty. Adrija received her Bachelor of Science in Human Biology and Society from UCLA. And today she'll be presenting her work examining pre- and postnatal maternal psychosocial factors in relation to children's cardiovascular health, the results from a systematic review. So Adrija, go ahead.
All right, thank you so much for the introduction. Let me go ahead and share my screen real quick. Okay, thank you for bearing with me. All right. All right. Thank you so much for being here. My name is Adrija. I worked with Farah, who is here on this call with us, and we studied pre- and postnatal maternal psychosocial factors and children's cardiovascular health, and we conducted a systematic review. So first, I want to ground down in the outcome of interest for our systematic review. Cardiovascular disease remains a leading cause of mortality and morbidity in the US and globally, accounting for 20% of deaths in the US and 32% of deaths globally. And historically, when we think of cardiovascular disease, we think of biological and behavioral risk factors, including blood pressure, cholesterol, diabetes, or diet and exercise. These have gotten a lot of attention as key drivers of cardiovascular disease, but numerous studies have also shown that psychosocial factors are important contributors to cardiovascular health and disease, suggesting that our experiences in society and how we feel about our experiences in society have an important bearing on our health. So before we move along, I want to first take a moment to pause and think about and define what psychosocial factors are. For this review, we define psychosocial factors as being of either intrapersonal or interpersonal types. And intrapersonal factors relate to psychological and emotional functioning. And interpersonal factors, as the name would suggest, is related to social connections and relationships. And psychosocial factors can be both adverse and protective. As we can see in our examples, both intrapersonal and interpersonal psychosocial factors can be positive or negative in nature. So intrapersonal positive factors can include flourishing and resilience, and negative factors can include depression and anxiety. For interpersonal, social support can be positive and protective, while exposures to violence can be negative. And when we think about psychosocial factors and how they relate to cardiovascular disease, we can think about this idea of developmental origins of health and disease. So DOHAD examines disease risk throughout the life course and thinks about how psychosocial factors from early life can influence health down the line for offspring. Within this theory, it is posited that the pathways can begin early in life, starting as early as the in utero environment. So here we have fetal programming as part of DOHAD. This is the theory that maternal stress impacts the development of children's HPA axis. And the HPA axis is important in children's cardiometabolic functioning later in life. And it's not just the prenatal period that's important. We also have to think about the postnatal period and early life. So the cascading effect of maternal practices can also have a bearing on children's cardiovascular health outcomes. So maternal experiences of postpartum depression or anxiety can negatively hinder maternal responsiveness to their infant, and that can have implications for child cardiovascular health. Now, to summarize, or sorry, to get to our review aim, our review was looking at research examining associations between early maternal psychosocial exposures and children's cardiovascular health outcomes. And our hypothesis was that across both the pre and the postnatal time period, negative maternal psychosocial exposures be associated with worse child cardiovascular outcomes, while positive exposures be associated with more beneficial child health outcomes. So now on to our methods. We had a search strategy that was composed of both the exposure and the outcome. So our exposure of interest was maternal psychosocial factors, and we included both prenatal and postnatal factors, and we defined postnatal as 1 year after delivery. For psychosocial factors, as I mentioned, this can include risk and protective factors. Our study wanted to examine both of these. We also included intra and interpersonal psychosocial factors. For our outcome of interest, we had child cardiovascular health outcomes. I'd like to take a moment to point out that child here means offspring. So we wanted to look at studies across the life course, not just during childhood. So we included both cardiovascular related diseases like hypertension, heart disease, diabetes that are often more relevant for later in the life course. And we also included preclinical biomarkers, including adiposity and blood pressure, which was more relevant for younger children. So studies that looked at children often looked at adiposity or blood pressure instead of cardiovascular disease, because that cardiovascular disease is not as prevalent in younger populations. Now on to our study descriptives. So we use 3 different databases to gather our papers. We looked at PubMed, Embase, and PsycInfo and screened our papers on Covidence. As you can see, we started with quite a daunting number of papers, and we whittled it down to 45 studies that were included in our systematic review. Now to break this down by the type of exposure. As I mentioned, we looked at both intrapersonal and interpersonal exposures, but as we can see here, there are a lot more studies that observed intrapersonal exposures than interpersonal ones. And the sum of the studies are greater than 45, I'd like to point out, because several studies looked at different exposures. And as we can see here, depression was the most studied exposure, and there were 27 papers that looked at depression as the maternal psychosocial exposure in the study. Also, we can see here that we've bolded the protective maternal exposures. Social support and parental cohabitation were captured in the interpersonal studies, although there were only 4 studies, so it was a little difficult to make any comparisons in that dimension. So for the rest of this presentation, we'll mostly focus on exposure type, so intrapersonal versus interpersonal comparisons, and exposure timing, pre and postnatal exposures. Now we're going to think about the outcomes. We were just looking at exposures, now we're switching into child cardiovascular outcomes. We split this up by the timing. So out of the 34 studies that looked at exposures in the prenatal period, 32 of those studies looked at adiposity measures. And adiposity includes BMI, fat mass index, waist circumference. And out of the 20 studies that were looking at postnatal exposures, 19 of them looked at child adiposity. So as we can see, adiposity was very well documented in this systematic review. Now we're going to think about some of these comparisons. I'm going to first start with timing, prenatal versus postnatal. Studies of psychosocial factors in the prenatal period tended to have expected findings regardless of the type of exposure. So what I mean by that is for both intrapersonal and interpersonal factors, the prenatal studies tended to find expected results. So expected based on our hypothesis. Also, I'd like to take a moment here to just walk us through what we mean by these different terms. Expected, like I said, confirms our hypothesis. Unexpected is the opposite of what we posited in our hypothesis. Null means that significance was not reached. The studies did not find significant findings. And mixed means that some of the findings were significant while others were not. And this could be on the basis of the outcome timing. It could be based on the outcome studied. Mixed is a pretty grab bag category. Okay, now studies of intrapersonal factors in the postnatal period tended to have null findings. So few studies investigated interpersonal factors postnatally, so comparisons across developmental periods were a little less informative, but let's look at what the graph has to say about this. As we can see here, the postnatal studies, there were a lot more in intrapersonal than in interpersonal. Although I would like to point out that both of the studies that looked at interpersonal postnatal exposures came to expected findings, whereas the postnatal studies that looked at intrapersonal factors came to null findings most of the time. Now let's get into our interpretation. First off, I'd like to point out that the evidence is inconclusive, and also we were unable to compare findings across risk and protective factors due to the dearth of studies on protective factors. So from what we did gather, we saw that the prenatal exposures were more consistently associated with child cardiovascular outcomes than postnatal exposures, but null results were quite common. Also, maternal interpersonal factors were more consistently associated with child outcomes than intrapersonal factors, regardless of the timing. Again, I do want to point out that there were less interpersonal studies. So does timing matter? It is unclear, but again, like I mentioned in the previous slide, there were more studies that came to expected results in the prenatal period. Fetal programming theory posits that these prenatal exposures may influence children's developing cardiovascular systems, and we could see that in a lot of these studies. For the postnatal period, there are quite a few confounders and mediating pathways at play, And these were not always accounted in the studies. This could lead to some of the heterogeneity that we found among our studies included. Now, I would like to point out that we had quite a broad scope for our review, and this had its strengths and its limitations. Limitations included that it was difficult to synthesize findings across a heterogeneous evidence base, and we were unable to do a meta-analysis given the wide array of exposures and outcomes that we looked at. However, we had some really notable strengths. And by having such a broad scope of our review, we're able to comprehensively look at the literature and guide future research. And we really were able to identify glaring gaps in the literature. We saw how few studies examined protective factors and interpersonal factors, and that the evidence largely focused on adiposity measures, specifically BMI. And so this leads us to our next steps. The next steps for our systematic review are looking at risk of bias, and this is looking at study quality, which is going to be important in light of the null results that were identified. We're also hoping to use the systematic review to guide more specific studies investigating mechanisms driving intergenerational health outcomes. So that brings us to the last slide here. I will keep this up. I won't read all of it. I am open for questions. Thank you so much.
Thank you so much, Adrija. That was awesome. And I have to say, especially, I have to give a hats off to you since I was your mentor for this project and you put a ton of work into this. So really wonderful work here. I will open it up to anybody who has questions.
Yes, Flo, go for it.
Well, I first just wanted to say that such a wonderful presentation and definitely someone to look up to as a first year. So I really appreciate you sharing everything today. I just had a question because I can see that this project is definitely has so many takeaways. And I know you mentioned there's still a lot of work to be done, but I was just wondering if you could use the information you got from this to think about what intervention or what next steps could we take as public health professionals. What would you recommend we take from this to implement like a program or an intervention?
That's a great question. Thank you, Flo. I think there's a lot of takeaways. I'm just going to focus on one that I had been thinking about even before I started doing this research. And the reason I even connected with Farah or Dr. Qureshi, I've been really alarmed by how much of public health looks at deficits and looks at risk factors. And again, this systematic review really confirmed for me that we need to look at protective factors. I'm going to put up a slide real quick. This was in my supplemental section. But as we can see, there were 4 protective factor studies versus 42 risk factor studies. And all 4 of the studies that looked at protective factors showed that that positive maternal psychosocial exposures protect against adverse child cardiovascular health outcomes. So I think that that is a really powerful finding, and it makes me more excited about thinking about how we can scale up what's already working, what protects people against negative health outcomes. And thinking about intergenerational processes, right? Interrupting the development of cardiovascular disease way early in the life course. So that's something that I took away from this and what I would like to see coming out of public health in general.
Thank you.
Maybe we'll also take Jennifer's question real quickly. I think we have a minute or maybe 2 to spare.
Oh, okay. Then I'll just leave a comment. I just thought it was really, impressive findings. I really enjoyed like your whole conversation about like, it is really shocking that there is such limited research on the protective factors, and I totally agree. I do think there's a lot of focus on the deficits here, but just amazing. I can't believe you went from literally almost 10,000 studies to like, I forgot, it's like 40 or something. I was like, what? That's insane. So I just want to say, thank you so much. And I really enjoyed your presentation.
Of course, I do want to highlight that is a collaborative effort, and I did not get it from 9,000 something studies to 45. Farah helped, and also we had another collaborator, Michelle, who doesn't go to Hopkins, but I do want to acknowledge her. I realize now she's not in my acknowledgements. Just a total oversight on my part, but it was not a solo effort.
But still impressive.
Adrija did a ton of work.
months.
So congrats to Adrija. You did a ton of work on this. Thank you so much. This is great. Now we will shift gears a little bit, and we'll turn to Caitlin Eng. So Caitlin received her Bachelor of Science in Molecular and Cellular Biology from the University of Arizona. And today she'll be presenting her scoping review of telemedicine-provided abortion care, evidence on efficacy, safety, and patient satisfaction. So Caitlin.
Yeah, absolutely. All right, can everyone see my screen okay?
Yes, looks great.
Perfect. Let me just bring up this. Okay, perfect. Well, I'll go ahead and start. Thank you so much for the introduction. As Farah said, I will be presenting on my master's essay, which is a scoping review of telemedicine-provided abortion care and the evidence on efficacy, safety, and patient satisfaction. My faculty reader was Sally, who's also in this Zoom room today, and I'm deeply appreciative of her help. So we'll get started. Alrighty, so my interest in the subject really stems from the unique circumstances we are currently experiencing. In 2019, we all went through the pandemic, which showed large gaps in our healthcare system, but really caused the sector to also innovate. And one of those innovations was the broader use of telemedicine as a form of care, and reproductive health services were also included in this healthcare evolution. What's also unique about our current landscape is the Supreme Court decision regarding Dobbs v. Jackson Women's Health Organization in 2022. And this decision effectively overturned Roe v. Wade and the constitutional right to an abortion, and allows states to make their own decisions regarding abortion access. Today, 25 states have abortion restrictions or bans that impact people's access to care and impacts 25 million people of reproductive age, particularly women. As a result, these people have turned to other solutions to manage terminating their pregnancy, which includes, but is not limited to, telemedicine services that provide medication abortion. Medication abortion is approved for use up to 10 weeks gestation, but is ultimately based on the provider's comfort in prescribing this form of abortion in later stages. In 2023 alone, 16% of abortions in the US were provided through telemedicine, indicating increases in this use of form of abortion care. And each of these points really demonstrates a need to understand the safety, efficacy, and acceptability of this form of abortion care to create evidence-based recommendations that promote the health of individuals and their communities. So with these points in mind, I decided to set out to synthesize the existing evidence regarding safety, efficacy, and patient satisfaction of telemedicine abortion care, given its increasing use. And specifically, I explored research on efficacy, serious adverse outcomes, and patient experiences surrounding the use of telehealth prescribed medication abortions. I started off my search by looking at 3 databases. These databases included PubMed, the Cumulative Index to Nursing and Allied Health Literature, and NBASE. And to refine the search, I, alongside the School of Medicine's librarian, created a search strategy that utilized Boolean phrases. And specifically, these phrases included telemedicine, telehealth, telecare, virtual medicine, and abortion, which were strung together. From there, I limited the results from the search phrase to include only studies that were completed in the US from January 2018 to January 2024. And I specifically used these dates in the setting because of the circumstances that led to a shift to telemedicine abortion care surrounding the COVID-19 pandemic and the Dobbs v. Jackson Women's Health Organization case that I mentioned in my introduction. This next slide is a figure that depicts the results from my search strategy and how I narrowed down the results to include the studies that I utilized in my review. Across all 3 databases, my search strategy yielded 296 results, which I input into my reference manager. And in doing so, I found duplicates and papers that weren't really relevant to the scope of my research specifically. which left me with a total of 10 studies that met my inclusion criteria. And I will be presenting the cumulative findings of those studies today. So first, tackling the idea of efficacy, the studies reviewed showed that telemedicine-provided medication abortion is 88 to 99.5% effective at terminating a pregnancy. I do want to note, however, that efficacy is at least 94 to 99% effective if we exclude one of the research studies that utilize misoprostol-only abortions. And this is really a good time to bring up that medication abortion can be conducted in one of two ways. Either with a combination treatment of mifepristone and misoprostol, or misoprostol only. And evidence shows that misoprostol-only abortions are less effective than the combination treatment, which is why that one study that included misoprostol-only medication abortions may not be comparable to those other findings that were found in the other studies. Aspiration medications are shown to be effective 98% of the time. So when you compare either of these efficacy rates for telemedicine prescribed medication abortion, it just shows that this form of abortion care is just as effective as in-person care. The next area I decided to evaluate was safety, and I decided to evaluate this through the incidence of serious adverse events, which included going to the emergency room, receiving a blood transfusion, or receiving intravenous antibiotics for potential sepsis. And what was found was that 0 to 7% of women reported experiencing serious adverse events. Specifically, 0 to 7% of women reported going to the emergency room about health concerns, 0 to 2.9% received a blood transfusion, and 0.5% received intravenous antibiotics. I also do want to note that no deaths were reported across these studies. And to compare the safety of telemedicine medication abortion to aspiration medication, again, or to aspiration abortion, studies show that 3.33% of individuals who obtain an aspiration abortion experience serious adverse outcomes. And these values just show that the risk of experiencing serious adverse events as a result of telemedicine-provided medication abortion, again, compared to the standard of care aspiration medication, is extremely low and may be deemed safe. The last component I analyzed was acceptability and satisfaction with telemedicine-provided medication abortion. And only a couple of studies explored this information in addition to safety and efficacy. But regardless of that, I decided to include that in my analysis. And the majority of women were content with the care that they received, or believed it was the right choice for them, and would recommend the service to a friend. No concrete numbers were really given for these results, as the papers that were published were mainly qualitative in nature, but it demonstrates a willingness and a desire of patients to use telemedicine abortion care. As with any research, there were some limitations I was able to identify. First of all, my methodology only included studies from the US. I did this to understand how our specific environment is currently affecting individuals, but it may be useful to conduct research in other settings that may have different restrictions or resources to begin to understand how these factors affect reproductive health outcomes. Another limitation that I found was that there's limited data on the outcomes of women who took this medication after 10 weeks gestation. Again, medication abortion is FDA approved for up to 10 weeks gestation, but there may be circumstances that cause individuals to take their medication after 10 weeks. For example, if a person gets this medication through an online service, there may be delays in the shipping, which causes them to take it after 10 weeks. Future research should be aimed at answering if outcomes vary for telemedicine prescribed abortions that occur after this time. And it may be also useful for future studies to compare misoprostol only and mifepristone and misoprostol combination treated abortions, as there may be some nuance regarding safety, efficacy, and acceptability that were not captured because we simply don't have the data on it. Lastly, I also found that a serious gap was that one of the 10 studies included data on transgender and gender nonconforming individuals. And I believe that this is a major gap in the literature just because there are outcomes that may be different compared to cisgender women, and is an area where future research can be directed to. Another area that needs reform is the cost of telemedicine prescribed medication abortion. In the studies that discussed acceptability and satisfaction with this form of abortion care, many women noted that cost was one of the biggest barriers to telemedicine prescribed medication abortion. And outside research demonstrated that online medication abortion ranged from $110 to $360. And future programming should aim to include sliding scales for obtaining this form of abortion care to enable bodily autonomy for all. Overall, these limitations are not fatal to the main findings of this review and should not detract from the key conclusion that telemedicine-provided medication abortions are safe, effective, and acceptable. Again, I set out to explore the efficacy, safety, and patient satisfaction regarding telemedicine-provided medication abortion. And to reiterate the findings of the 10 studies I reviewed, the research shows that terminating a pregnancy is 88 to 99.5% effective. 0.70 to 7% of women experience serious adverse effects, and telehealth medication abortion is widely accepted and supported by users of this form of abortion care. These data points suggest that telemedicine-provided medication abortions are effective, safe, and accepted among users and indicates the utility of this form of abortion care. So with that, I will leave you with some of my references if you'd like to look further into this. And I just want to thank you for your time and everyone's support, and I welcome any questions anyone has.
Thank you so much, Caitlin. That was wonderful. I will open the floor now to any questions that the audience has.
Thank you, Adrija. Yeah, go ahead.
Of course. Thank you so much for your presentation. I learned a lot. It was really well compiled, as I mentioned in my comment. I had a question about what your hypothesis was before you got into the literature review, and I was just wondering if you were surprised by anything, or if this confirmed what you already know. I know that you know a lot about abortion already, so I'm asking this question. I know it's a topic of interest, so yeah.
Absolutely. So I did know that it was going to be safe and effective because, again, like these medications have been around for a while and it's been used pretty widely. And again, no deaths have been reported. I was surprised by the acceptability of it, though, the increased acceptability. I do think with it being, with the environment that we're currently in, I do think there are a lot of skeptics around it. So I was surprised to see that the majority of women did support it. So that was definitely interesting, but I knew it was going to be safe and effective. And especially with the rulings that have like come out in the past couple of weeks, especially from my home state of Arizona and also in the Supreme Court, I was incredibly interested to be like studying this, especially like with our environment. So yeah.
Great. Any other questions from the audience? All right. Well, that was a wonderful presentation, Caitlin. Thank you so much for sharing that important work. And it's a nice bridge to our final presenter. Sarah Jahangeer received her Bachelor in Arts in History and Philosophy of Science from the University of Pittsburgh. Another one of my mentees for this MSPH paper process. She will be presenting today on abortion in Muslim majority countries, the results from a scoping review that she conducted. So Sarah, go ahead and take it away.
Hi, thank you for that introduction. Let me just share my screen real quick. One moment. Okay. Do you see that?
Looks great.
Okay. So thank you for introducing me. I just want to thank Farah Qureshi, my primary reader, for all of her guidance and support and advice. With that, I'd like to get started. So to ground the research that I did more specifically on abortion in Muslim majority contexts, I just want to lay the foundation for abortion as it relates to policy and practices and religion more broadly. So religious values or religion obviously they relate to abortion because of, concerns about life, or more importantly, the right to life. So all of these factors influence each other and interact with each other to affect personal attitudes and practices in these wider contexts. So research shows that typically more religious-leaning political environments result in more restrictive or conservative abortion policies. And I just like to note that this is also usually coupled with social contexts in which stigmatization against abortion is prevalent. So with that said, I just want to talk about the health risks associated with environments where there are restrictive abortion policies, and this includes unwanted pregnancies and their associated increased risk for infant mortality, seeking unsafe and illegal abortions, and this also includes post-abortion complications and incomplete abortion complications, maternal morbidities, such as infections or hemorrhages or damages to the vaginal tract, and mortality, which is at a rate of 8 to 18% worldwide. So with that, we can look more closely at the context in which I studied, which was Muslim majority countries, which obviously are influenced by Islamic beliefs. And though all of these countries have a diversity in their abortion policies because of a lack of clear guidance in Islam on what abortion, when it's permitted, or just any general guidance about that. Typically, there are 4 instances in which Islam allows abortion, and that is in the case of rape, in the case to protect the woman's life, the mother's life, in the case of fetal anomalies, and before 120 days of gestation. So with that being said, and bearing in mind the health risks associated with restrictive abortion political environments, that leads me to why this research is needed in the specific context. And studying this will help address needs that, women in restrictive environments would need to be met. And also this can apply more broadly to environments where religious values influence abortion policies. So this leads me to the objective of the study. I conducted a scoping literature review and saw which themes emerged from the literature regarding abortion in Muslim majority countries, and then I put them in the context of the social ecological model to identify where the research gaps are and how to fill them. So the first important definition, I've already used this term and I will be using it a lot more, is Muslim majority countries. And this I defined as countries in which more than half of the population is Muslim. So according to the World Population Review, this is 47 countries as of 2024. And I want you to remember this map because I will be showing a similar map shortly. Some other important definitions, the social ecological framework. And this is a model that considers factors like the individual, relationship, community, and societal level factors, and which protective factors and risk factors are associated with a certain health issue, in this case, abortion. Individual is pretty straightforward. Relationship, which is, interactions between individuals. Community, defining that as institutions. So in this context, it would be health systems like clinics or hospitals, and providers are those institutions' representatives. And societal level factors like religion, policy, and other overarching factors. Induced abortion. So this study looks at abortion with an emphasis on the intention to remove the embryo or fetus from the uterus. And this is to be contrasted with spontaneous abortion, or also known as miscarriage. And lastly, unsafe abortion, which is the termination of pregnancy by people lacking the necessary skills or an environment lacking minimal medical standards, or both. So for the methods for this paper, again, as I mentioned, it's a scoping literature review. I looked at articles on PubMed, and I searched abortion with Muslim and Islam and included literature on those topics. And I excluded studies if they were about spontaneous abortion, not grounded in Muslim majority countries, not in English, or inaccessible. So I also wanted to mention that when looking at these studies, rather than trying to summarize what all the results were, I focused on looking at the research topic because that showed what the research that's taking place looks like and what further research needs to be done. So I want you to recall the map that we saw earlier. This obviously is way less populated than the one before. Out of the 47 Muslim majority countries, this is only showing 12. So the studies took place in 10 countries, and one study included the Middle Eastern and North African region, more specifically Morocco, Tunisia, and Egypt. So that one study had 3 Muslim majority countries. But yeah, as we can see, there is quite not, there's not as much representation as there needs to be. Another way I wanted to show the results was by the number of studies per country. And as we can see, Iran has an overwhelming majority. And most of the studies, most of the time, it would just be 1 study per country. And another way I wanted to show the results was mapped out in the social ecological framework. And first of all, I just wanted to note that I really like this presentation of the visual of the model because it shows the interplay and the overlap between the different levels. And so that takes us to the results. As you can see, the individual level has the most studies and the relationship level has the least. So these are the topics that were identified across the different studies. And as you can see, there are some themes that emerge in multiple levels, and we'll be getting into those more details soon, like attitudes and access to care. But some other ones that are important to note are demographic characteristics, whether that's the abortion seekers characteristics or the provider's characteristics, contraceptive use before abortion, intimate partner violence, and social norms. So the first theme that I wanted to draw attention to is attitudes. And as you can see, this spans across almost every level. On the individual level, I wanted to note that the majority of these studies studied cases in which abortion seekers would permit or deem acceptable to seek an abortion, and that would be in the cases of fetal anomalies. And fetal anomalies that were studied were deafness, Down syndrome, thalassemia, and those are the ones that are coming to mind right now. But from the community providers perspective, this looked at how community providers could improve their care and how they thought about providing care and whether they agreed with the abortion laws and just their perspective. And then lastly, the policymaker perspective. This was studying the knowledge of policymakers on existing policies and their attitudes about wanting to shift them or if they're comfortable with them. And yeah, just their general attitudes regarding abortion. The next one that I want us to look at is access to care. And from the individual perspective, this looked at whether they were seeking unsafe or illegal abortions and the quality of those abortions. And from the community side, this looked at what the health system was able to provide and how providers were trained and their capability to provide meaningful access to abortion care. And then lastly, contextual factors. So I want to draw attention to the fact that the study that took place or looked at the Middle Eastern and North African region and Turkey both looked at policies related to abortion and how that affects abortion access. And the study that took place in Palestine looked at how occupation affects health systems and access to care. And the study from Bangladesh looked at specifically the Rohingya refugee population from Myanmar that are in Bangladesh and how humanitarian emergency situations affect access to care. So that leads us to the discussion. And while these studies looked at Muslim majority contexts, their findings can be applied to a much broader context as well in any situation or environment where religion has effect over policies. And some gaps that were identified in this research were, as I mentioned before, the Muslim majority countries were not represented enough. There are many countries that we still want to see research from to better understand abortion and what the unmet need is there. Also, as I mentioned before, the relationship level was the most underrepresented. And research on the cases outside of religiously permitted abortions is needed. As I mentioned, many of the studies when looking at individual attitudes asked about therapeutic reasons rather than elective reasons. And I wanted to mention that most of the studies all asked married women their experiences with abortion and did not surveil unmarried women's experiences. And though this research is needed in the future, it's important to bear in mind that this is ethically done and that these people that are asked are protected if they're disclosing, things that are not legally allowed in their contexts. So in conclusion, we need further research on abortion in Muslim majority countries, especially, in the underrepresented populations. And this can contribute to our growing understanding of the broader context of abortion as it relates to religion and policies. So, are there any questions? Okay.
Thank you so much, Sarah. I see a hand up already, so I'll let Jennifer ask the first question.
Hi, Sarah. Really enjoyed your presentation. I thought it was really insightful, and I liked how you showed us visually through the maps. I was just curious, did you see the other Muslim majority countries in the excluded studies? And if so, what were the reasons why they were? Was it because they were spontaneous abortions instead, predominantly?
Yeah. So the most common reason for the studies being excluded was because they were not from Muslim majority countries. And the ones excluded because of that reason, it was usually due to the fact that they didn't look at intentional induced abortion.
Thank you.
Dory, do you want to go ahead?
Thank you so much, Sarah. That was amazing. Sorry, it's a little loud where I am, but I'm hoping you can hear me. I was wondering if you showed that map, or you showed that table of the countries that had the most research, the Muslim majority countries that had the most research on this topic, and Iran was the top of the list. And I was wondering if during your research you came across why that might be, or if you didn't, do you have a hypothesis on why that seemed to be the most represented country among the ones that you found articles for?
Yeah, so I'm not exactly sure why, but I think it's important to note that many of those studies were conducted by the same researchers and they were quite related to one another. So I think having that background information and background research made it easier for them to just continue growing that knowledge base rather than starting fresh, which might be the case in other contexts.
Thank you.
Great. And Sharik, do you want to, I see your hand up as well.
Sorry, I'm having a lag on my end, but Sarah, great job. As a Muslim myself, it was really interesting to kind of hear this, different perspective on abortion. I just wanted to see if you found any research on Muslim communities within the US, and if there's that, and then as I have a second question, in that were there any barriers from other family members that were listed in any of the studies as being barriers to the abortion?
Yeah, so to answer your first question, there was a lot of research that I came across, but obviously it couldn't be included in this since it does, America's not a Muslim majority country, but that's definitely important to look into. And the second question that you asked, so yes, family members' opinions and their attitudes that was an emerging topic that came up, although usually it wasn't the main focus of the study, so I couldn't place it into the relationship category. The only clear-cut relationship category study that I came across, both of them were regarding intimate partner violence. So while it was studied, I think it would be interesting to see more studies that put more of a focus on that rather than just one question out of a survey of 50 questions.
Great. Well, it looks like we have reached the end of our time together, almost exactly on the nose. Really wonderful work, Sarah, Caitlin, Adrija, Jennifer. We really enjoyed listening to the fruits of your labor over the past few months. All of your presentations were outstanding. And I hope you enjoy the last couple weeks of the term as we head towards graduation and are able to give yourself a big pat on the back for this major accomplishment. So thank you again. We'll give everybody another round of applause, and I hope you guys can all attend our other sessions as well in, I guess, next Wednesday, right, Sally?
Yep, next 2 Wednesdays.
Next 2
Lots more presentations, so.
Great. All right, take care, everybody. Have a good day.